research that is agile and patient-centered, education to increase the number of clinicians treating us, and also community, where we focus on practical advocacy around barriers to care. Most of you know us best from our largest project to date, Remission Biome. As a nonprofit, our work is funded by grants and private donations. We will have a link later on. If you are able to, please contribute and help us continue to grow. More importantly, our wonderful team of volunteers has moved the wheels of our organization. All of us have a personal interest in advancing research and care of infection-associated chronic illness. To stay in touch with us and hear about upcoming events, please subscribe to our newsletter. We started the Clinicians Roundtable with the goal of having expert clinicians share their knowledge with those who want to improve their care of ME/CFS. We aim to expand the pool of clinicians available to treat us and help us improve our quality of life. And today our speaker is Dr. Brayden Yellman. He is a board-certified physician in internal medicine and rheumatology at Bateman Horne Center. He completed a BS in biology at Washington University in St. Louis, Missouri, and a Doctor of Medicine at University of Texas in Houston. He completed a residency at Exempla Saint Joseph in Denver, Colorado, and a fellowship in rheumatology at the University of Pennsylvania in Philadelphia. Dr. Yellman joined Bateman Horne Center in January 2019. Prior to this, Dr. Yellman practiced at Intermountain Healthcare, diagnosing and managing complex health issues and illnesses in an outpatient clinic and consulting with network providers. He developed and implemented a patient referral triage system to expeditiously identify particularly ill patients and provide them with rapid access, with a focus on the underserved populations suffering prolonged waiting periods. Dr. Yellman helped create curriculum to educate primary care providers in recognizing, diagnosing, and managing rheumatological diseases. Since being at Bateman Horne Center in 2019, Dr. Yellman has meticulously evaluated complicated new patients, many of whom are in the early stages of ME/CFS or fibromyalgia, and each requiring 4 to 6 hours of intense initial evaluation with subsequent follow-up. He has also adopted or consulted with many long-standing Bateman Horne Center patients. Dr. Yellman is an active collaborator on educational projects and develops and presents curriculum to educate medical providers in recognizing, diagnosing, and managing ME/CFS, fibromyalgia, and comorbid conditions. He provided the intellectual context for a series of 6 short videos designed to rapidly teach how to recognize ME/CFS, as well as how to diagnose and manage both orthostatic intolerance syndromes and post-exertional malaise. Dr. Yellman is conversant in Spanish and has been a tireless educator, volunteer, and leader in causes for this community and profession. He has also been recognized for his volunteer work with marrow donor programs and has received high ratings by patients for his bedside manner, communication, compassion, and humanism. Welcome to today's roundtable. We are very happy to have Dr. Yellman with us today.
Thank you, Isabel. Let me get the screen share going here. All right, so today I've been asked to cover a lecture in maybe a little more detail than I had in the past. This is one I gave to basic scientists, trying to touch on some of the clinical comorbidities that we see in ME/CFS that we're starting to recognize are playing a larger role in the way that we manage patients and likely even in the pathophysiology of the illness. There's been a lot of focus on post-exertional malaise. There's been lots of focus on orthostatic intolerance and how to diagnose and manage it. There's lots of research on that. So this is actually to touch on some of the things that I haven't seen captured in as much of the basic science research as I would hope for in the future. So as stated earlier, I work for the Bateman Horne Center. We are a non-profit center of excellence dedicated to furthering clinical care research and provider and patient education in ME/CFS, long COVID, and other infection-associated chronic conditions, as well as their clinical comorbidities. So regarding ME/CFS and its comorbidities, in 2015, the IOM definition of ME/CFS illuminated the shared symptoms that must be present for all who receive a diagnosis of ME/CFS. And of course, this is helpful for identifying populations that we want to study, especially in a research population. But we have increasing recognition of comorbid symptoms and illnesses that modify or exacerbate these already aberrant metabolic, immune, or neurological dysfunction that we do see in ME/CFS. And we think these conditions are aggravating and propagating the complex multisystem illness and leading to greater suffering and disability. Some of these conditions are actually present prior to the onset of ME/CFS and may be present as young as puberty for people, but may exist independently of ME/CFS or long COVID or other infection-associated chronic conditions, may exist independently of post-exertional malaise, but they're still present. And we kind of postulate that they may be predisposing factors for the development of these type of infection-associated chronic conditions. And ultimately, I suspect that our model of disease and an ultimate cure for ME/CFS will need to consider the interplay of these comorbid conditions and their influence upon the development of, exacerbation of, and propagation of ME/CFS if we're really going to move the needle forward. So one of those, of course, is hypermobile Ehlers-Danlos syndrome or hypermobile spectrum disorders. And there's actually a growing number of studies that are starting to identify this in patients with infection-associated chronic conditions. But one stated here is a self-reported data in a cross-sectional study of those with ME/CFS suggests that 15.5% of those with ME/CFS have joint hypermobility. And again, this is self-reported. I think the number is much higher than that. And then in long COVID patients, that number is as high as 28% reporting generalized joint hypermobility. Also, in a self-reporting prospective observational study, individuals with generalized joint hypermobility were approximately 30% more likely to experience chronic symptoms after recovery from infection by SARS-CoV-2. And then many of these patients ultimately went on to meet criteria for ME/CFS. Hypermobile type Ehlers-Danlos is, of course, the most common subtype of EDS and is thought to be the most common of all hereditary disorders of connective tissue disease. Its prevalence is as high as 1 in 5,000 people, 80 to 90% of which are the subtype of hEDS. So that's over 10 million people in the US alone. And again, I think these are pretty conservative estimates. Unlike with classical or vascular EDS, there is no single gene mutation causing hEDS that's been identified. It's certainly multigenic, and there are many environmental factors that play a role here. hEDS is more likely a phenotypic spectrum disorder in that way. So how do we make the diagnosis? Traditionally in clinical medicine, we use something called the Bateman score, which is to look for hypermobility in several areas. Of course, is there hypermobility bilaterally in the fifth finger or the pinkies? Is there hypermobility in the thumbs? And you can kind of see here if the arrow's coming up, the motions that we have patients do. Is there hypermobility in the bilateral knees? Can people hyperextend their knees when they stand? The same is true with the bilateral elbows. And then lastly, can somebody bend forward and place their palms flat on the floor without stretching ahead of time? And so you get a point for each of these conditions bilaterally and for being able to put your palms to the floor. So technically, the diagnosis depends on having a score of 5 or greater in adults, 6 or greater in children. People are more hypermobile as they are kids. And then as people age, they become less and less hypermobile. So the score goes down to 4 out of 9. I would comment that there are other types of hypermobility that are important as well. And I know that the Ehlers-Danlos Society is working on updating the diagnostic criteria for hEDS. It's not just the Bateman score on their website. They have a whole other section of family history and other sort of environmental determinants that play a role in their current diagnostic criteria. But they're looking to update those based on evidence-based research. And of course, on physical exam, if I see patients that can wrap their fingers around their wrists, for example, that's another type of hypermobility. You might see among many others. So I think that we probably still underestimate hypermobile spectrum disorder and that these criteria may be a little too narrow at this point. So what is the relationship between EDS and other ME/CFS comorbidities? Well, we know that those with hEDS or other hypermobile spectrum disorders are often found to have things like mast cell activation syndrome, small fiber polyneuropathy, gastrointestinal dysmotility, central nervous system, what I would call neuroanatomical complications, which include things like craniocervical instability and Atlanto-Axial instability, and things like occult or acquired tethered cord. We also see a high incidence of vascular pathologies, particularly vascular abdominal pathologies like May-Thurner's, Nutcrackers, and even median arcuate ligament syndrome or celiac compression syndromes. So moving into mast cell activation syndrome. Mast cell activation syndrome is characterized by either a pathological accumulation of mast cells in organs or tissues, but probably more importantly, the aberrant release of mast cell inflammatory mediators in tissues, which is sometimes, or I should say often, independent of IgE-mediated allergic triggers. So a lot of sort of mast cell cancers really are represented by a pathological accumulation of mast cells, but this is really more about how these mast cells are behaving and how they're responding in a hypersensitive manner to all sorts of environmental triggers. So the exact prevalence of MCAS in ME/CFS is still being investigated, but much like ME/CFS, patients with mast cell activation syndrome can remain symptomatic for decades before they are appropriately diagnosed or treated. And one study actually compared 80 patients with mast cell activation syndrome to 136 long COVID patients and found a nearly identical symptom presentation and severity analysis between those two groups. So here you can see general population controls in this spiderweb plot and those before they had a COVID infection. These are mast cell patients who were diagnosed prior to COVID becoming an issue. And this is a similar spider plot here for patients experiencing post-COVID, long COVID symptoms, and it matches up very closely with those mast cell patients. So mast cells may actually serve as hosts for SARS-CoV-2 by expressing the ACE2 receptor, which is an important receptor for the virus upon host cells. And upon stimulation by SARS-CoV-2, mast cells rapidly secrete preformed granules as well as cytokines and chemokines within 6 to 24 hours. Vasoactive mediators from mast cells allow these cells to infiltrate multiple organs, including crossing the blood-brain barrier, and we wonder if this could be potentially the beginning or a trigger for long COVID or PASC. Pharmacotherapy used in mast cell-related disorders has actually been found to be effective in reducing the severity of both the acute viral illness caused by SARS-CoV-2, but also to reduce the incidence of development of long COVID in the first place if these drugs are taken during active infection. So even things like Benadryl, Claritin, and other H1 blockers taken during an acute infection do appear to reduce the chances of someone ending up going on to develop long COVID in the first place. And in fact, I recommend to my patients with things like hypermobile Ehlers-Danlos or orthostatic intolerance in POTS or mast cell who do not have post-exertional malaise, who do not meet full criteria for an infection-associated chronic condition, that they do prophylactically use H1 and H2 blockers during acute infections like this. So there is a huge overlap in the prevalence of hEDS in orthostatic intolerance in POTS and in mast cell activation. Nearly 1 in 3 patients with MCAS has a comorbid diagnosis of hEDS in a sample of almost 38,000 patients diagnosed with either disorder. Another study shows that 66% of patients with POTS and EDS also meet symptoms for MCAS. So we really believe there's a huge interplay in the incidence, prevalence, and continuation and worsening of this illness between these conditions. Specifically in hEDS, we think that MCAS may be playing a lot of roles. Irregular, recurrent, or chronic release of mast cell-mediated cytokines, such as pro-inflammatory molecules, growth factors, proteases, has actually been linked to the presence of hEDS or hypermobile spectrum disorder and other heritable connective tissue diseases. Mast cells in connective tissue cause microenvironmental changes to the extracellular matrix, including IgE-mediated autoreactivity. Mast cell inflammatory changes have been implicated in contributing to laxity of blood vessels, with pooling of the blood in the extremities, which of course we see in dysautonomia syndromes, POTS, etc. In families with heritable mutations in genes encoding elevated tryptase levels, which is one of the proteases that's released from activated mast cells, 28% of those patients were actually found to have joint hypermobility, which is nearly double that of what we find in the general population. And some literature reviews have even gone on to suggest that there is little evidence suggesting that mast cell activation syndrome and hEDS are even distinct significant clinical entities. Of course, there's a lot of significant overlapping symptoms that are considered vague and subjective, that are hard to measure, so this could play a confounding role, but I think we're going to learn a lot more about this in the next 5 to 10 years. These are conditions that we see in infection-associated chronic conditions that are also comorbid with mast cell activation syndrome, and in many cases we believe may be driven by mast cell activation syndrome, or at least exacerbated and propagated by it. And those include orthostatic intolerance in POTS, post-Lyme syndrome, fibromyalgia, chronic migraines, multiple chemical sensitivity syndrome, irritable bowel syndrome, PTSD, endometriosis, interstitial cystitis or chronic prostatitis, vulvodynia, craniocervical instability or Atlanto-Axial instability, and occult tethered cord syndrome, to name a few. So when we think about mast cell activation clinically, it's easy for physicians to look at it and say, oh, activated mast cells, what are they famous for? They release leukotrienes that are part of asthma. They release histamine and are part of allergies and urticaria. They release tryptases, right? But it's a lot more than that. And in fact, when activated, mast cells can release over, the real number here, I needed to update this, I'm sorry, is actually over 1,200 different mediators. This is just 130 listed here from one paper. But there are all kinds of different mediators, and they are often different depending on what activates the mast cell and often what tissue that mast cell is present in. Additionally, mediators may be released through traditional mast cell degranulation, but they can also be discharged in a degranulation-independent manner. What are the triggers of mast cells? Mediators can be released through traditional mast cell degranulation, or alternatively, oh, sorry, that's the same slide. Okay, so mast cells are found in different tissues, and they behave phenotypically in those different tissues, including their activating triggers, their membrane receptor expression, and the cytokine or chemokine release that they propagate. Activated mast cells, no matter the initial stimulus, may send distress signals via neurological or immunological pathways throughout the body, and that can trigger mast cell responses in distal tissues as well. So you may have a medication you take or a food that you take and have a mast cell reaction to that in the GI tract. Not only does that create a local inflammatory response, but that response is also propagated to mast cells throughout the rest of the body and can include a mast cell activation in the central nervous system, in the autonomic nervous system, in the skin, etc. Mast cells are found in the brain, and particularly in the hypothalamus, the thalamus, the third ventricle, the pituitary and pineal glands. And in MCAS, mast cells are often notably activated and affected by emotional stress via effects of the corticotropin-releasing hormone. Mast cells also appear to regulate permeability of the blood-brain barrier, as we stated before when looking at the relationship between MCAS and acute COVID infection. Mast cell mediators like histamine and tryptase that are released by these activated mast cells can also activate microglial cells in the brain. And of course, these microglial cells, acting as part of the innate immune system, release their own pro-inflammatory molecules. And microglial cell activation and neuroinflammation has, of course, been implicated in triggering multiple brain disorders, including the brain fog and many of the other symptoms of ME/CFS, long COVID, and infection-associated chronic conditions. So what are some of the actual clinical triggers here? Well, they're really extensive. It can be onset of heat or cold, or just a very rapid temperature change. Physiological stressors on the body, those can be emotional, they can be physical, like an orthostatic stressor, they can be pain or chronic pain. They can be environmental stressors, changes in weather or barometric pressure, the presence of pollution. Here in Salt Lake, we get quite a bit of inversion this time of year. Pet dander, pollen, etc. Exercise, vigorous exercise, significant fatigue, or in some cases even post-exertional malaise and infection-associated chronic conditions can trigger this. Very famously, food and beverages, as well as medications and drugs. Natural odors, chemical odors, perfumes and scents. I had a patient who I met early on in my initiation into infection-associated chronic conditions, she was sitting in the room across from me and started having a mast cell reaction and told me, "I can smell your deodorant from across the room, and this is what's triggering it for me." It was pretty remarkable. Venoms, of course, from insects, from jellyfish, snakes, biting insects, etc. Infections. So an infection like we talked about before of SARS-CoV-2, for example, but also other simple infections, a cold virus, bacterial or fungal infections, etc., can trigger a mast cell response. Mechanical irritation, friction, or vibration. And of course, we think about clinically dermatographism in this case. It's an easy way to sort of screen for continued active mast cell activation in a patient, even if you're treating them. And then, of course, sun or sunlight. There are a lot of people who develop photosensitive rashes that are mast cell mediated. And of course, when I was practicing as a rheumatologist, I would be seeing patients to rule out lupus for photosensitive rashes. And the main difference there is that, of course, they're different on a biopsy as well, but the main clinical difference is that these urticarial rashes come and go within a matter of hours in patients with mast cell activation, whereas they are present and persistent for days to weeks in somebody with a ANA-mediated autoinflammatory condition. The symptoms of mast cell activation are extensive, and I think a lot of these we attribute specifically to the histaminergic and leukotriene-based release. Those are the most obvious to us as clinicians. I think there's a lot of symptoms that are going on underneath the surface that we are not always recognizing either, or that are just not something that a patient can track, right? Can a patient really feel that the extracellular matrix of some of their connective tissue is slowly being degraded? I don't think so. But at least clinically, we look for things like food allergies or intolerances, worsened fatigue or malaise, especially after eating, anaphylactic reactions, all kinds of dermatological symptoms, hives or urticaria, itching, swelling, flushing, redness of the skin that comes and goes, patchy, poorly circumscribed types of rashes. We think about cardiovascular symptoms, which have a lot of overlap, of course, with our orthostatic intolerance or chest pain, lower blood pressure, high heart rates, lightheadedness, dizziness, fainting. Musculoskeletal symptoms seem to be worse when mast cell activation is present, joint pain, muscle pain. I've actually seen several patients who have seronegative rheumatoid arthritis. And interestingly enough, when we treat their mast cell activation syndrome, their presumed rheumatoid arthritis symptoms do seem to get better, independent of what's going on from a disease-modifying anti-rheumatic drug therapy perspective. Of course, we implicated mast cells in crossing the blood-brain barrier and propagating neuroinflammation and contributing to neurological symptoms as well as migraines. So, of course, headache, cognitive impairment, anxiety, mood swings. Interestingly, even things like tics or OCD behaviors have improved when people are treated for mast cell activation. And then the peripheral nervous system, numbness, tingling, small fiber polyneuropathy symptoms. Nasoocular symptoms are pretty famous. Rhinosinusitis, congestion, itchy, watery eyes, respiratory symptoms that we attribute to asthma, sore throat, hoarseness, globus sensation in the throat, wheezing can all play a role here. And then there's a lot of gastrointestinal symptoms. Nausea is a really big one. Diarrhea, particularly within an hour of eating with urgency. Alternatively, constipation intermixed with diarrhea. Acid reflux, stomach cramps, bloating. A lot of these will really improve if you get down to successfully treating mast cell activation syndrome. So how do we test for mast cell clinically? How do we make a diagnosis? There are several labs that we can rely upon, but to be honest, in a clinical practice setting, when I'm not enrolling patients in a clinical study, I often do not rely on these tests. And the reason is because though they are specific, serum and urine testing is specific, it is not terribly sensitive for a diagnosis of mast cell activation syndrome. Samples, when they're drawn, need to be put into pre-chilled containers and remain on ice. They even need to be put in centrifuges that are cooled or refrigerated. And there's just really few labs that are qualified to process these samples in that way. And the other problem is you have to catch symptoms immediately as they're occurring. These are things that are waxing and waning by minutes. These mediators don't last for hours. You have to catch them as they're being released. And so that also contributes to decreased sensitivity with the testing. But we do, when we need to have that testing present, we do use a total serum tryptase, which is very specific for mast cells. Just doesn't last long, it degrades quickly. Elevated serum histamine can sometimes be found. We do look for 24-hour urine levels of things like 11 beta prostaglandin F2 alpha, leukotriene E4, but maybe most prominently the N-methylhistamine, and that's because that can last up to 12 to 24 hours. It's a little easier, a little more sensitive to catch there. But probably the best way to make the diagnosis in a general clinical practice is via tissue biopsy. And often that is GI tissue. So many of these patients will have gastrointestinal symptoms. Many end up having an EGD and a colonoscopy, and many of them may have some diffuse kind of nonspecific erythema. They test negative for H. pylori. They don't have anything suggesting celiac disease, and they just are told, oh, go on a proton pump inhibitor. We're not sure what's causing this. If you go back to those slides and ask for CD117 staining, which is for that c-KIT receptor, you'll often see huge amounts of mast cell infiltration. So that can be one way to really document in the chart a kind of guaranteed or almost guaranteed diagnosis of mast cell. But really in clinical practice, when a patient has an infection-associated chronic condition and they have hEDS and they have POTS and they have symptoms of mast cell activation, I don't always put a ton of effort into chasing these things down before I start treating. I think an empiric trial of therapy, when your clinical suspicion is high, when your pretest probability is high, can really be clinically diagnostic, and you can start helping your patients sooner rather than later. So what are our goals of MCAS management? Of course, we want to reduce inflammation at connective tissue interfaces that may lead to increased blood-brain barrier permeability, or increased vascular permeability with endovascular inflammation. Of course, we want to reduce the increased intestinal permeability with GI translocation. We want to reduce breakdown of connective tissues, supporting joints, muscles, and neurovascular structures, right? If that possibly is contributing to tethered cord, CCI or AAI, of course, we want to reduce that. We also want to reduce new or perpetuated innate immune dysregulation that may actually contribute to the development of ME/CFS, long COVID, or other infection-associated chronic conditions to begin with. Again, not everybody that has MCAS or POTS or hEDS will go on to develop these conditions, and I think that by reducing mast cell activation syndrome, we may be reducing the incidence of that in the first place. We want to reduce symptoms of allergy, atopy, asthma, and anaphylaxis. We want to reduce triggers for neuroinflammation and triggers for migraine and headache propagation. And of course, we want to reduce triggers for exaggerated dysautonomic behaviors that mediate things like orthostatic intolerance, gastrointestinal dysmotility, and even sympathetic overdrive responses. So sometimes in clinical practice, patients will say, Dr. Yellman, I'm really fatigued. I can't function. I really don't care that much about my constantly runny nose right now. And while I can appreciate that, I really see those symptoms as sort of the canary in the coal mine that say, look, this is an iceberg and we're only seeing the tip of it. There is a lot going on under the surface that we can't always appreciate, that we can't always measure easily, but that we think is important in the propagation of your entire clinical complex. And so I tell people treating mast cell activation is necessary, but maybe not sufficient for getting you back to where you want to be. It's like flour in a cake. You're not going to get a cake without the flour. But treating mast cell alone, maybe you're not going to say, hey, I'm 100% better. I'm feeling like I'm back on track just yet. You need it there to get there, though. So management for mast cell activation syndrome is extensive. We're getting better at this all the time. A low histamine diet does work. It's sometimes helpful diagnostically for patients if they can do it, but it is just not easy to maintain for anyone. It's a really strict diet. Some of my most sick patients end up doing it anyway because they're having awful symptoms without it. Diamine oxidase is a supplement that reduces histamine in what is taken in by food and medications. Remember, histamine is not only released by mast cells, but is actually a trigger for mast cell activation in the first place. So when people take this with meals, especially around the holidays, a lot of people like to eat aged cheeses, for example, or drink wine. They can sometimes get away with that a little bit with some diamine oxidase. Traditionally, histamine 1 and histamine 2 blockade has been a big part of reducing symptoms. But I'm wondering if we're going to start moving in a direction where that is sort of insufficient, where we know that that's reducing the impact of histamine and histamine's propagation of other mast cell symptoms, but it's not preventing the release of other mast cell mediators as well. So what are we not capturing there when we're just using H1, H2 blockade? Benadryl, of course, is part of that too. Leukotriene blockade can be surprisingly effective here. I use montelukast, Zafirlukast, and other leukotriene blockers quite a bit and can see a huge difference in day-to-day symptoms for patients. We do rely heavily on mast cell stabilizers like flavonoids, luteolin, quercetin, and rutin, ketotifen, cromolyn sodium, which can be compounded or come in a liquid form. I've started using anti-IgE biologics like omalizumab or Xolair quite a bit more when a patient has an elevated IgE level. I generally, personally, will do that only when their IgE is about 40 or above. That is sort of an arbitrary number. There's not data necessarily supporting that, but that's where I've sort of found the threshold for it having clinical relevance for patients. We're starting to use more of c-Kit tyrosine kinase inhibitors like imatinib, and even hydroxyurea has been proposed in some cases, though I have not personally used that. I think it's important to point out that mast cell reactions to actual drugs are rare, but are exceedingly common to excipients found in those drugs. All the things that make a pill, or all the things that make liquid a liquid. And so sometimes these medicines actually exacerbate mast cell activation syndrome when you're actually trying to treat it. And if you're looking for why someone is doing worse and you can't figure out a trigger for their mast cell, sometimes going back and looking at their medications, trying to find out if you can get their other support medications manufactured by a different manufacturer, or hold them for a little while until you get mast cell under control before reintroducing them, can be extremely valuable in management. All right, moving on to some of our other clinical comorbidities, and thanks for your patience with mast cell. I think it's a really important, relevant condition here for these patients. Small fiber polyneuropathy plays a notable role in these patients as well. And of course, small fiber nerves are small unmyelinated sensory C fibers or thinly myelinated A delta fibers. They're often postganglionic or sympathetic autonomic axons. These nerves are small diameter fibers that innervate most organs and tissues. And of course, we think about them from a sensory perspective and pain and paresthesias, but they have a lot of autonomic functions as well that include things like heart rate response to deep breathing, heart rate and blood pressure response to Valsalva, heart rate and blood pressure response to tilt, our pseudomotor or sweat response, and even our GI functions. And of course, they are found in lots of tissues, and loss of axon innervation in myovascular structures has often been recognized in small fiber polyneuropathies. So we know that loss of myovascular innervation can lead to dysautonomia-like symptoms and things like vessel patency that lead to arteriovenous shunting of blood. In other words, this vessel patency may be an abnormal response and we don't get blood appropriately flowing into capillary beds. You can actually get a left to right shunt from artery to vein that skips those capillary beds. And that may be one of the contributors to some of the findings that we see in David Systrom's work with invasive cardiopulmonary exercise testing and reduced oxygen uptake at tissues. So this is a study that I thought was pretty interesting, looking at small fiber polyneuropathy in hEDS. And so they performed quantitative sensory testing on 79 hEDS patients with amnestic complaints and found that 70% of them met criteria for small fiber polyneuropathy. They also performed skin biopsies, which of course look for the intraepidermal nerve fiber density, which is our gold standard currently for small fiber polyneuropathy diagnosis. And they found that again, 78% of patients met criteria for small fiber polyneuropathy based on this diagnostic test. And what's interesting here is sort of a heat map of amnestic complaints. And you have patients defined as no small fiber polyneuropathy possible, SFPN, and definite. So they made a diagnosis of definite when these hEDS patients met criteria for SFPN based on their QST and their nerve fiber density skin biopsy criteria, and that was 58% of patients. And then the probable was when they met criteria for small fiber polyneuropathy based on one of the two of the tests. But when you look at all of the patients, and then those diagnosed with, this is just all patients with hEDS, and those diagnosed with small fiber polyneuropathy, you can see those heat maps of amnestic complaints overlap very significantly. Small fiber polyneuropathy is likely playing a major role in our GI symptoms for patients as well as mast cell activation. The gut is densely innervated by small fibers, and the loss of these fibers can result in a wide range of abdominal and digestive symptoms, which include our GI dysmotility or hypermotility. Sometimes we have vacillation between those two states, to be honest. We'll do a gastric emptying study and it may be normal or hypermobile on one time, and then you repeat it again in the same patient in a different circumstance, and it looks like gastroparesis. postprandial nausea and vomiting, GERD, weight loss, anorexia, cachexia, diarrhea, constipation, and a lot of the symptoms that we've attributed to irritable bowel syndrome may actually be related to mast cell activation and to small fiber polyneuropathy. Looking at gastrointestinal dysmotility a little more closely, one study evaluated 129 patients referred to a tertiary neurogastroenterology clinic, and 49% of these patients were actually found to meet criteria for joint hypermobility syndrome. Again, our overlap is extensive here. An unknown etiology for GI symptoms was significantly more likely in those with joint hypermobility syndrome versus those without. And in this small study, 12 of 17 of these patients evaluated were found to have delayed gastric emptying. There was another study done in EDS patients at the Mayo Clinic that noted abnormal gastric emptying in 22% of EDS patients. And as we stated before, sometimes this is delayed and sometimes it's accelerated gastric emptying, but it's certainly abnormal either way. When you use wireless motility capsule testing or smart pill testing on 20 individuals with idiopathic autonomic neuropathy and unexplained GI symptoms to evaluate GI transit time, we found that transit times were predominantly abnormal and delayed in the foregut, in that upper GI region. Contractility abnormalities were far more prominent in the hindgut and the colon, and were present in 85% of patients. And detected neuroanatomical overlap between, the study, detected neuroanatomical overlap between the presence of autonomic reflex abnormalities and the transit time and contractility abnormalities, a direct correlation between the presence of those two seemingly unrelated symptoms. Craniocervical instability is gaining a little more traction in this field as well. And we're starting to find ways to recognize this a little more frequently. What is it? It's a manifestation of incompetence or hyperlaxity of ligamentous and bony elements that support the cervical spine and the craniocervical junction. So that is the C0 to C1 area, as well as C1 to C2. And we then see increased motion at these sites. CCI is traditionally thought to arise, traditionally in medicine, thought to arise from neck trauma abnormalities and expression, structure, and function of the fibrillar collagen, and can lead to this ligamentous incompetence or hyperlaxity, which then leads to the increased mobility at these joints. And it's postulated that collagen or ligamentous incompetence may also be triggered by or accelerated by inflammatory conditions like mast cell activation, though we still need more research on this to say that definitively. So the increased mobility and instability that we see here can precipitate deformation of the brainstem or the upper spinal cord, including the ventral brainstem, with compression there and basilar invagination. We also get increased mobility and instability that creates traction on the vertebral arteries and may alter venous or CSF outflow from the cranium. And we sometimes have even diagnosed increased intracranial hypertension in these patients as a result of this. There is increasing recognition of the formation of axon retraction balls or bulbs as the result of stretching or deformative stress injury upon neurons, and these are findings that are actually similar to those we see in diffuse axonal injury of the brain. And we think that stretching of these neurons causes pathological calcium influx, altered gene expression, and even apoptosis. So you can imagine how this would affect neurological functioning as a result. Traditionally, when we are looking for CCI in patients in front of us in a clinical setting, we look for symptoms of the cervical medullary syndrome. And that, of course, can include headaches, specifically a lot of basilar headaches right at the base of the back of the skull, with associated neck pain. A lot of patients will have pretty remarkable dystonia of the muscles of the neck and shoulder girdle. It's really interesting because you think of craniocervical instability as hypermobility, and these are hypermobile patients. But what you actually see oftentimes clinically is that patients have a really tense guarding position and very, very significant dystonia of the neck and shoulder girdle. And it's almost like that's an adaptive mechanism to reduce the motion at those sites. And so these patients are less responsive to things like acupuncture, to muscle relaxants, to physical therapy than you might otherwise expect. We see diplopia, dizziness and syncope, vertigo, memory loss, lots of tinnitus and altered hearing, dysphagia, dysphonia, speech difficulties, altered vision. Usually that's a waxing and waning vision issue. Numbness and paresthesias in the arms or legs, weakness in the arms or legs, choking or aspirating on food with a sense of globus, emesis, frequent nighttime awakening, snoring, sleep apnea, ataxia or gait changes, altered menses or altered sexual function, and the list goes on. So assessing for craniocervical instability diagnostically can be done by imaging, although we don't always jump to that immediately. I often will try other things clinically first because we don't actually have a unified set of guidelines for what the imaging needs to be in these patients. And I'm hoping that that is something that changes in the next few years as we get some of our neurosurgical specialists together, that we can create some formalized criteria for this. But right now, those don't technically exist. Imaging is often done, or I should say, is better done upright than supine. I think part of the reason we don't always capture this for patients is that patients are only symptomatic. Patients are only in the provocative positioning when they are upright, and most of our imaging is not done upright. And of course, the effect of gravity upon an unstable cervical spine, especially from C0 to C2, progresses as the day goes on, as gravity weighs the head down, and you start to see more and more the actual anatomical pathology responsible for symptoms. We do look for things like dynamic flexion and extension views, which are really critical to identifying pathological anatomy in patients. But you can imagine that this is really hard for imaging centers to get when you put patients in provocative positions that irritate dysautonomia, that cause severe nausea and dizziness, that cause patients to even pass out. They can't hold themselves in that position to actually capture the compression of the brainstem that we're looking for. Most imaging centers are really unfamiliar with these type of imaging protocols. They don't know how to get people in the correct positioning, and even if they do, it's difficult to get patients to stay in it. And there's just very few radiologists or even neurosurgeons, frankly, who are trained in appropriate evaluation of these conditions. I've had neurosurgeons tell me, pound their fist on the floor, tell me there's nothing wrong with this MRI, with this imaging. And then we take it to a neurosurgical specialist who says, look, this is what I'm seeing right here. They can identify where the pathology is. And then when patients actually seek treatment, they get better. So it's not that they're seeing something that's not there. It's that we have a long way to go in improving our protocols and our guidelines for this type of diagnosis. So it's not something that I think can easily be done by all clinicians out in the field if you suspect this, at least not yet. What about acquired or occult tethered cord, which is of course often found concurrent with CCI, but they can be independent as well. This is an anatomical restriction of the normal movement of the spinal cord via the filum terminale with tightening or tethering. A healthy filum is a fibrous, collagenous, and elastic band connecting the conus medullaris to the dural sac at that S2 level. But in tethered cord, the filum appears to be morphologically altered with fatty tissue. There's dysplastic axons or nerve twigs. There's fat and vascular lacunae, and even congested veins. The pathology is thought to be from forcible flexion and stretching of the spinal cord against the filum. And then you get a secondary tissue damage and repair, local inflammation. And I put mast cell activation syndrome there in question mark, although there are biopsies that show mast cells infiltrating these tissues when people go for neurosurgical tethered cord release. And then we also expect altered gene expression in this area as part of that inflammatory response. The classic triad of symptoms we may see in tethered cord includes things like a neurogenic bladder, and I do think it's important when you suspect that to refer patients to urology for urodynamic testing. I've had to twist urologists' arms. Oh, I think it's just their meds. Oh, they've had 6 children. They have incontinence for other reasons. Ask for the UDS, and you'll be surprised at what you'll find. Lower extremity weakness and or sensory loss, sometimes altered gait as a result, and lower back pain is really the classic triad. But we see things like unsteady gait, loss of lower extremity sensation, lots of pain that's migratory in the lower extremities. I've seen patients actually with restless leg syndrome that might be attributed to tethered cord and seems to improve if that tethered cord is surgically released. Urinary frequency and urgency, frequent UTIs, although there's a lot of overlap there with interstitial cystitis and mast cell activation, dysuria, urinary retention in particular. Patients will not have to go to the bathroom or not get a signal to need to urinate until all of a sudden it's really urgent and they have to run to the restroom, or they're going to end up having an accident. Other times they'll sit down and it takes 10 minutes to empty their bladder, or they stand up and walk around and go back and then sit down again to urinate. It's amazing how often this is found. Gastrointestinal problems or dysfunction, lower back pain, a pulling sensation. Often that pulling sensation is felt at the area that we suspect for CCI, right at the base of the skull. And it's interesting when patients will bring their knees up in flexion, it relieves that pulling sensation. When they pull their legs down into extension again, that's when that pulling sensation will happen. Alternatively, it's interesting if you put a patient in cervical traction, especially in the upright position, sometimes that traction creates more pulling on the tether cord and can actually elicit those tether cord symptoms, more sensory symptoms or motor symptoms in the lower extremities, more urinary incontinence, or a sense of numbness or saddle anesthesia can be diagnosed by sort of a quick little trial of cervical traction. We also sometimes will have patients in the office try to walk on their heels, and if they're struggling to do that, or if they often have been somebody who, quote, toe walks, that's often a telltale sign that we need to look for tethered cord. So hEDS patients frequently present with symptoms of tethered cord syndrome without the traditional, as it's called, finding of low-lying conus medullaris, traditional being because it's found in patients who kind of develop this congenitally. Morphological and biomechanical testing of the filum terminale in 78 hEDS patients indicated limited elastic properties there, exposing the conus medullaris to non-physiologic stress forces, and these findings were compared to 38 cases of low-lying conus in patients without hEDS. hEDS patients may benefit from the filum terminale excision even in the absence of radiographic low-lying conus medullaris, especially when they have symptoms that we just talked about before, and especially when those symptoms are present in the context of the entirety of an infection-associated chronic condition, POTS, MCAS, small fiber polyneuropathy, GI dysmotility, etc. So as mentioned before, urodynamic testing is one of the things I reach for first to help evaluate for symptoms, especially in patients who screen positive for any neurogenic bladder type symptoms. Somatosensory and evoked motor, evoked potentials can be really helpful. Though finding a practitioner to do this is challenging. I hope that will change for us in the next few years. We will sometimes get a 3 Tesla, particularly high intensity prone and supine lumbar spine MRI. But again, there are a few protocols out there, but none has really been universally accepted as a standard of care quite yet. And most imaging centers don't know how to do these correctly. You have to be able to screen out a lot of artifact when patients are on their stomach because of breathing. So these are still really not available to the general public, unfortunately. Of course, remember that a normal supine MRI is not adequate for evaluation alone. So you're really looking for what happens with the conus medullaris when you change from supine positioning to prone positioning, and does that conus medullaris shift? If it moves less than 25%, that's when the suspicion for tethered cord really goes up. Surgical detethering is a viable option for patients who present with moderate to severe symptoms and with some at least suggestive radiographic findings. Interestingly, some cases may actually retether again over time. And we wonder if this is because of continued abnormal forces from CCI, if it's related to postoperative mast cell related inflammation or other sources of innate immune system inflammation. In some cases, a surgical Gore-Tex has actually been placed to help prevent retethering. The filum terminale may actually be part of the sensory motor system involved in spinal alignment and in sensing non-physiological stress forces from excessive spinal movements. And as such, that filum terminale could be acting as a stabilization, in some cases, CCI and AAI. So I bring that up to mention that if patients have a tethered cord release, this can change what is going on in the context of CCI if it is present. In some cases, it actually allows for significant clinical improvement. It's almost like that downward tethering was sort of holding people in a symptom provocative position for their underlying CCI. And by releasing that, the brainstem or the irritated neurological areas maybe move into a slightly less irritated position. And I've definitely seen this clinically for some patients. On the other hand, the tethering may actually be keeping people in an anatomical position that is favorable if indeed CCI is present. And so when you untether and there's a shift in positioning, that shift in positioning may also be disadvantageous to that patient and actually make their symptoms worse. So patients need to sort of be counseled and aware of that going into a surgery. And it's why I think some people who have both end up having both done concurrently, surgically, a CCI fusion, as well as a tethered cord release. What about venous congestion syndromes? So May-Turner syndrome is found in quite often in our patients with infection-associated chronic conditions, with hEDS, with mast cell activation syndrome. This is defined by extrinsic venous compression by the arterial system against the bony structures in the iliocaval venous territory. And most commonly, that includes the left common iliac vein by the right common iliac artery. Has an estimated prevalence of 2 to 5% in EDS patients, I think highly underrepresented there. It's more common in females presenting in the second to third decade of life. Symptomatic patients often present with extremity pain, with swelling, with venous claudication, or signs of venous insufficiency. Most common, of course, in that left lower extremity. And then a Nutcracker syndrome is also found in higher prevalence here, and this refers to compression of the left renal vein between the aorta and the proximal superior mesenteric artery. Symptoms include things like hematuria, orthostatic proteinuria, and left flank pain. We are also seeing increased recognition of venous congestion in the cranium or venous outflow tract obstruction syndromes in conditions like infection-associated chronic conditions, long COVID, ME/CFS. And that sometimes leads to an idiopathic intracranial hypertension. So 20% of people with ME/CFS actually have elevated CSF pressures when you perform a lumbar puncture. But 85% of the ME/CFS patients who do not have an elevated CSF pressure on lumbar puncture still note symptomatic improvements, things like diminished headache, improved fatigue, less brain fog after that lumbar puncture, after the removal of some of the CSF, after reduction in that intracerebral pressure, with these symptomatic benefits sometimes lasting for weeks. So what does that actually mean, right? The criteria that we use for an elevated opening pressure may be maybe not specific for patients with hEDS. Maybe patients become more symptomatic at much lower intracerebral pressures, and we need to have sort of different diagnostic guidelines for those patients. So what is causing these obstructions? We're still learning about this, but obstructions can arise from abnormal venous anatomy with venous stenosis or tortuosity, as well as from anatomical impingements, things like Eagle syndrome or pseudo-Eagle syndrome. Can occur in the context of craniocervical instability or Atlanto-Axial instability, spinal stenosis, disc herniations, all the complications we see in patients with hypermobile symptoms and low or reduced, I would say, soft tissue integrity that end up having more anatomical complications. And it may actually even be related to venous congestion syndromes like May-Turner's or Nutcrackers. There are some interesting case reports where patients may go in for surgical removal of a thoracic mass that's having some venous congestion. And after removal of that mass, all of a sudden their headaches and their fatigue and their brain fog get better. And so you wonder if that mass was actually, its venous congestion in the chest was actually contributing somehow to intracranial hypertension symptoms in these patients in ways that I'm not sure I can fully explain right now, but we need to look into this more. And so you can imagine that the presence of May-Turners or Nutcrackers may also play a role in that, and makes you wonder, should we be looking for these syndromes more? Should we be sending people to surgeons for stenting or for auto renal transplant, Nutcrackers, et cetera, more than we are? Would that help not only with abdominal symptoms, but with more systemic symptoms as well? I think that's something to be watching for as we move forward in the care of these patients. I thought this was really an interesting chart as well. So people with ME/CFS and hEDS may have, as we talked about, uncharacteristic forms of IIH that do not meet our traditional definitions for the elevated opening pressures on lumbar puncture. And a lot of times these patients won't even have papilledema, right? I do send them to ophthalmology to look for that, but when it's not present, it certainly doesn't rule that out. And I think we actually need to think about this as an active dynamic system. It's not just constant increased intracranial pressure. That pressure is changing based on whether a patient is upright, based on whether they are now laying down. It's very positional. It depends on the barometric pressure. For me, it very much depends on altitude. And I say for me because I'm located in Salt Lake City, and patients will feel very different when they go and leave Utah for places that are closer to sea level. And so it's really postulated that a lot of these cases may actually be even a vacillation between increased intracranial hypertension and then spontaneous CSF leaks with intracranial hypotension that arises until the pressure once again builds up and the cycle returns. And there have been others that have kind of postulated this before. There's Dr. Maxwell has talked about the spiky leaky syndrome in the past. And that is maybe one type of this where it occurs over the course of a 24-hour period. But I think this can also occur dynamically over the course of weeks to months, right? Pressure slowly builds up and then there's a quick release. And they may be symptomatic for a little while from hypotension, and then all of a sudden pressure builds up again. So we really need to think of these as dynamic systems and think about positioning and all kinds of other variables when we're assessing these patients, and to say, no, they have intracranial hypertension, no, they have hypertension. I think that we get lost in that nomenclature and trying to figure out which one it is, and I think it's really often both. So with that, I will say thank you for your attention. This is commonly, I think, how we as clinicians, I think in the broader sense, have treated patients with complex chronic illness in the past, and I hope that is changing. And of course, the zebra is sort of the mascot that the hEDS Society has taken on for hypermobile spectrum disorders. And I thought it was kind of funny that I actually was a zebra for Halloween and was thinking about zebras all the way back to first grade. So thanks again for your attention.
Thank you so much, Dr. Yellman. How long of a time period do you have for questions?
I have a few more minutes.
Like a few more, as in like you've got 15 or you've got 45? That makes a difference on how we prioritize which questions we tackle.
Let's go for about 25 minutes, if that's okay.
Okay. Yeah, that's right. I just wanted to make sure we didn't run you past you're like a hard stop. So we'll first start off with Dr. Malcolm, if you have any questions.
Great. I absolutely enjoyed that talk. I think it was a profoundly comprehensive review of what's going on. And I think I wanted to underline a few things, which is a quote from Paul Farmer, who's a famous doc who did a lot of work in Haiti, who, would tell his students, it's about inflammation and anatomy. And I think that was one of the big things that hit me as an ME long COVID doctor, of what is happening in patients who have EDS, who have this predisposition for anatomic changes, and then what happens. And so I'm going to just make a few comments because I just absolutely enjoyed the talk. And I have one question. I do have a hard stop. I have to run to see a patient in a few minutes. But very briefly, I work for a clinic called Rhythm. We're a telemedicine clinic. So I only see patients remotely. I'm licensed in about 12 states. I wanted to make just a few comments. So one is ME was relegated to this corner of, inappropriately called a psychiatric disorder. And we were not prepared for what happened with long COVID. So we went from an illness that was, 1.8, 2 point something million people to 10 to 20 to 30 million people in this country alone with this illness. So I really just wanted to make the comment of, this idea of getting testing, of, you have a test and what are the logistics behind it? So you want to get maybe like looking at papilledema, pressure in the brain. You want to look at an MRI and you get it standing. It is so difficult to get standing MRIs. And I think Dr. Yellman, you did an incredible job like talking about this. This is so profoundly painful for patients. And if this lecture is being kind of geared towards doctors, there's so much information in this lecture about not only the medicine, but also how do you get things done? And, talking about MCAS and alone and getting the GI biopsies, tracking that GI biopsy down, in Boston, and the patient now lives in Seattle, and then getting it stained, that takes months. And getting testing that might not be 100% accurate, this just takes so much time. And so I think that, really going over the lecture and all the things you said, I've lived this experience with my patients. And so thank you for really doing that. I absolutely agree with your statement about this kind of dynamic concern that is going on with like the CSF pressure or whatnot. And we want to assign a test to something, but it might not have captured it because the test might not be good, or it might not just be the appropriate test at that time. And that's like really, really profoundly frustrating. I have one question. I do have to run. I have not been able to figure this out in my head. I use a lot of H1 blockers for MCAS, but I don't know what the ramifications are of that in terms of reducing the acidity in the gut, and then the concern about accumulated infections like Clostridia. and an absorption of vitamins and minerals. So some good data out there that, you know, B1 supplementation will help with fatigue. I've seen profound iron deficiency in long COVID, copper deficiency, et cetera. And I'm just wondering what Dr. Yellman has to think about that question.
Yeah, I think there's an appropriate concern there about the use of those medications, but in my general sense of things, and this is just my clinical sense, it's not data driven, it seems like patients often have much less or have a reduction in those nutritional deficiencies when we get really good or absolute control of mast cell activation syndrome and when we help with GI dysmotility. I didn't talk about treatment here, but I'll say it right now. There is this horrible stigma against metoclopramide, and for good reason, right? At high doses, when it's used for gastroparesis in people who have, nerve damage from diabetic gastroparesis, it causes pretty severe symptoms, extrapyramidal symptoms. They're scary, they're irreversible. But that's not what's going on in this patient population. Their nerves are not damaged or dead in that way. They're just not firing correctly. And I have kept myself to 5 milligrams twice a day or less, sometimes as low as 2.5 milligrams once in the morning. And you would be amazed how much of a difference that makes in GI motility. So getting GI motility and mast cell controlled, I often see those things correct. The other thing, though, you're right about the profound iron deficiency. Some of that may be gastrointestinal in nature. I think also we're recognizing that a lot of people have, a lot of women specifically have gynecological disorders, endometriosis, and other complications that are really appearing to be mast cell mediated. And as we start to go back, we talked about GI biopsies, but I'm starting to have my patients who get things like hysterectomies for really heavy dysmenorrhea and iron deficiency. I'm having them have CD117 and c-Kit staining. We're seeing mast cells all over in those tissues as well. I've seen more women that have rejected IUDs or had them implant or even just shot them out of their uterus, to be honest, than I've ever seen before in this patient population as well. So I think that that may also be playing a role. But yeah, we have a lot more to learn on that front for sure.
And I think that this being such a profoundly large problem in medicine now, I think the more that we educate other doctors about this, I often tell my patients, you kind of have to see it because there is so much, I don't want to say controversy, but people will run up and say this is an MCAS, and it's very, very hard on patients. I've got to run to see a patient, but I also wanted to say I absolutely love that you included the ICD-10 codes in your lecture as someone who has to physically write those into a note. So thank you. So I got to run, everyone, but thank you so much.
Yeah, the other thing I would state too, just I'm sorry, I lost my train of thought. I had a good comment on what you had said, and I lost my train of thought. It'll come back to me, I'm sure.
Thank you.
Thank you.
So, okay, so for next questions, we'll go to the Q&A for any ones that people might have, and I'll pull you up if you're still in the chat, if you're still here, and I will then allow you to speak your question. If not, then I will just go ahead and read it out. So first person bringing it up is Athena Hall. If you want to ask either one of your questions, you have two in here, go right ahead.
Thank you. I have them in front of me. I don't have them in front of me, actually, so if you could read them on my behalf, I'd appreciate it. I think one really alluded to how we can obtain in Canada. We have not much of anything. We will never see a neurosurgeon, and many of us have all of the anatomical issues which you described, CCI, AAI. We have had imaging across to the US. Is there anything we can do or prepare or build in conjunction with your centers, which will allow increased education for MDs? To date, we've been bringing them US-based handouts, but it would be really nice if patients who have studied and researched and built this body of knowledge as well alongside you could assist in preparing materials for handout.
Yeah, so we have a pretty big education arm at the Bateman Horne Center. It's a big part of our mission, and we have created numerous resources that are present for free for everybody on our website, with various different goals in mind, covering all of these different topics more in depth. We have lectures, we have handouts, we have PEM crash survival guides, we have instructions to for emergency room doctors, for patients to bring in when they need to go to the emergency room. We all know that's sometimes disastrous for our infection-associated chronic conditions. So I would start there, and we're still always trying to add to that and improve upon those resources. You know, this is a really difficult, complicated subject on how we move this field forward, right? I think on one level, we need to do better with our primary care physicians. I mean, the prevalence of ME/CFS and ME/CFS long COVID now is so high that when you, at least in the United States, I've looked at numbers that suggest that there are over 30 patients with ME/CFS or long COVID with some related dysfunction at work or school or in their home life that every single primary care physician, family medicine, internal medicine, or pediatrics will see if you divide it up by the numbers, and up to 8 disabled patients per primary care physician. So we, on some level, have to start there. We have to at least make the diagnosis. We need to know what post-exertional malaise is and reduce harm. We need to have screening for orthostatic intolerance in these patients. The American Heart Association just came out with a paper, I think it was this week, actually asking cardiologists to do orthostatic screening, a full heads-up tilt or a 10-minute standing passive lean test, or what we've called a NASA lean test, in all patients diagnosed with long COVID. And I think that's a huge gain in the field. These things will trickle down eventually, but we have to start at primary care and identifying and just minimizing harm. If we do that, we've come a long way. And I think that's a very different approach from how do we manage these really sick patients, which of course, who's going to do that, right? What specialty does it belong to? Are we going to have enough specialists who do this day in and day out to take care of these patients? I don't know how we're going to get to a place where we can do that, where we have standardized, screening tools and radiological procedures, right, that actually help us make these diagnoses. We're a long way from that, but I can say that those of us who do this clinically are trying to work to create those systems. The neurosurgeons that I have worked with in the past, we are talking about trying to find a way to publish data, to look at case series of patients with the clinical data that we have as a center at Bateman Horne Center before they were to undergo neurosurgery, and then after, and to talk about what we can expect from these surgical procedures, and then what still is not always fixed by them, what things we still have to manage, or what creates better outcomes in these circumstances. There's some data that, and reports just online even, that patients who've had craniocervical fusions, of course, may not always do well. Some do really well and others don't. Why is that? Well, we suspect some of it might actually be not great mast cell activation control in the post-surgical period. So we're trying to look at those things and publish on that. And the hope is that that eventually trickles into more interest in the field, and things explode eventually. And I know that we're also working, I'm actually writing a paper right now to the federal state medical boards in the United States to try to ask them to provide CME, to encourage CME on long COVID to providers across the country, and to hold a minimum standard of care to not do harm, to not force exercise upon those with post-exertional malaise, to do orthostatic testing, and to say, look, if there are patient complaints, and of course there's tons of them right now because nobody was taught in medical school or residency or fellowship about these conditions, that that these complaints can be funneled into CME and education for these physicians so that they can get better and treat patients better in the future. And interestingly, if we are lucky enough to get that published, the hope then is that that actually opens doors for writing test questions for the American Board of Internal Medicine, for the USMLE, et cetera. When there's test questions that ask about how to reduce harm and PEM and orthostatic intolerance, then your medical schools and residencies and fellowships are going to start teaching to it. So there's a lot of work to be done on so many different levels, and I can only begin to imagine what the right things are to do to get us where we need to be. But everybody here, I hope, is doing their part in trying to help advance that cause.
Thank you. We appreciate your tenacity in these areas and making a difference with new medical graduates in the future. Thank you.
All right. So next question coming up is, looks like it'll be from Cynthia Johnson. If you are ready to go ahead and ask your question.
I am. Can you hear me?
Yes, we can.
Thank you very much. Well, it's a great talk. I wanted to know what specialties, I've had ME/CFS since 2009. So in this day and age, what specialties are most likely to be able to help ME/CFS patients with MCAS diagnosis and treatment? And then my other question was, do you think Sicca-Sjogren's syndrome is a comorbid condition of ME/CFS? It seems to pop up a lot with people.
Yeah, those are both really good questions.
Yeah, thanks.
So as far as what specialty does ME/CFS and MCAS belong to, that is a really complicated question. And I think in many ways, it goes back to how have we designed our healthcare systems, and our primary care providers are not given very much time, and you're allowed one problem in those circumstances. And of course, that doesn't work for chronic multisystem illness. And then our subspecialists are also overburdened, and they are taught. I know I was certainly taught that if it's not a positive ANA and it's not a diagnosable rheumatological condition, you say, I'm sorry, but suppressing your immune system with methotrexate is not going to be the answer for you, even though I know something's wrong. Let's get you back to somebody else that can help you. And I know before I even myself learned about infection-associated chronic conditions that I was seeing this, and I was seeing people with photosensitive rashes that would come and go. And I'm sorry, this is not lupus. I don't think suppressing your immune system is going to help here, but I can appreciate that this is strange, that these are not good symptoms. I had patients who were rule out dermatomyositis, and they could stand up. They had, good proximal muscle strength, but they're standing in the line there waiting to get checked in by the front desk was what was excruciating, and what made them almost have to sit down and fall down. And I didn't know what I was seeing at the time, but clearly it was ME/CFS and orthostatic intolerance. I'm trying to, and would love to have a lecture series that is, how does ME/CFS and the comorbid conditions, how does it present in your specialty, right? And I would start with rheumatology being one myself. Patients will come in, rule out lupus with photosensitive rashes, and they actually have mast cell. Patients will come in with this type of weakness in their lower extremities. Think about orthostatic intolerance and dysautonomia syndromes. I'm sure we could do that for other subspecialties, but I don't think it's going to end up living in any one particular specialty. I think we all have to step up. We need help from our neurologists. We need help from allergy and immunology. And that reminds me what I was going to state before that I forgot when Dr. Stuart was talking. Allergy and immunology could be a huge assistance specifically for your question in regards to mast cell activation syndrome management. And I've sent patients to allergy immunology because sometimes I'm apparently not allowed to prescribe Xolair or anti-IgE biologics according to insurance, even though I've done it before as a rheumatologist. So we get help from our allergy immunologists, and some are really great and really help. And then there's others who will say that mast cell activation syndrome doesn't even exist. And I think that clearly, if you look in the literature, there's overwhelming support for mast cell activation syndrome, and we're only going to move towards progression in that field. But I remind myself that there is a difficult political situation in that case, and a lot of allergy immunologists, especially when they're not part of academic centers, their bread and butter practice is allergy desensitization shots. And if you go and say, if you suspect that there's a big percentage of those patients that actually have mast cell activation syndrome and they need to be managed differently, you've changed the entire way that specialty practices medicine and how they earn their money. And so I know that because of things like that, there's some resistance in that field to really adopting mast cell activation syndrome on the level I think we'd like everyone to. So it'll be really interesting to see how that changes and progresses and modernizes over time. So not an easy question to answer there. And then, of course, the question about Sjogren's syndrome or Sicca. So I think we have to remember that keratoconjunctivitis Sicca symptoms are really common and are not always due to Sjogren's syndrome. And they're very often due to some of the comorbid conditions we see in these infection-associated chronic conditions and to the meds we use to treat those. So I start from that particular place. Sjogren's is interesting and difficult to diagnose in a lot of ways, but I think we are relying upon lip biopsies with actually seeing what we call a focus score, or a high number of lymphocytes per a small microscopic area, to make the diagnosis, much more than we are looking at kind of traditional serological markers like SSA and SSB. And I could go on a whole tirade about how we've switched to multi-beat analysis testing, and that's all that's available. And there's really high false positive and false negative values for just ANA testing alone. So if I really want to make a diagnosis of Sjogren's syndrome in a patient, I usually do try to go for some kind of pathological biopsy, which is asking a lot of patients. And the only reason I would do that is if I think it's going to change my management of that patient. And so if a patient has dry eyes and dry mouth, even when I put my rheumatology hat on, a lot of times we would treat the dry eyes and dry mouth conservatively. We use sialagogues, we get ophthalmology involved, we get dental medicine involved. There's a lot of great tools on the Sjogren's syndrome website to help, and that helps with keratoconjunctivitis sicca, whether it is medication induced, whether it's Sjogren's induced, whether it's related to sarcoidosis or granulomatous disease, another common cause, whether it's related to hepatitis or HIV, other things you should be screening for with keratoconjunctivitis sicca. It's only when they have additional systemic symptoms that I think could be related to Sjogren's that I really get biopsies and say, I need this information because it might actually cause me to change my management to use immunosuppressive techniques. So things like peripheral neuropathy, like concern for interstitial lung disease. These are the type of symptoms that I sort of screen for if I think someone has Sjogren's that make me want to pursue a biopsy and a quote formal diagnosis. And might actually alter my management from what I'm already doing for an infection-associated chronic condition. Do I think there is a higher prevalence of it in these patients? To be honest, I'm not convinced of that, but I'm not entirely against the idea either. I know there's some data that suggests that Sjogren's is certainly more common in patients with dysautonomia and POTS, but I've looked at those studies and I think the way that Sjogren's was diagnosed and defined in those conditions could have been a little more stringent. And so I do think there's a lot of confounding factors in those studies. And it's certainly, I don't see it in my practice to the level that it's been reported in studies for what that is worth. So I hope that starts to answer that question. The other thing I'll do if I have a patient I'm worried about for Sjogren's, it is helpful to test for complement deficiency. It's helpful to look for things like cryoglobulins, even to follow things like an ESR and a CFP, traditional inflammatory markers. And if you see things like hypocomplementemia, you see lymphopenia on a CBC, you see some of these kind of signs, you do worry about a more aggressive or clinically relevant type of Sjogren's. Not to say that dry eyes and dry mouth aren't clinically relevant, but I mean scary clinically relevant. And then I do start to worry about things that we see in Sjogren's, like an increased risk for myeloproliferative disorders, lymphoma, et cetera, and just kind of make sure I'm thinking about that if a patient ever develops weight loss and fevers, et cetera. So there is a lot to think about there, but is there a higher rate of Sjogren's in these patients? I'm not quite sure. Does it exist? Yeah, definitely it does.
Thank you so much, Dr. Yellman.
Right, and then we have one more question that we're going to ask. It comes from, again, the Q&A. It's an anonymous person, so I'll read the question. And it's also relevant for me too, because I've also had these effects too. So it's like you'd mentioned that tics and OCD may decrease with MCAS treatment. Have you seen a connection between MCAS and PANS?
Yeah, this is not my greatest area of expertise, and I'm not pediatric trained, although one of my colleagues, Melanie Hoppers, is. There is an evolving knowledge that there is likely a connection there. There was also an interesting study that I was looking at just last week that was detecting autoantibodies to the brainstem, the same areas that we're interested in CCI, AAI. There's direct autoantibodies to the brainstem in PANS and PANDAS that they're detecting now, which is pretty fascinating as well. So I think we are going to find out that mast cell plays a role in propagating those pathophysiologies. It may not be the only contributing factor there, but certainly take a look in the pediatric literature for more on that, and I hope that develops further in the future.
Thank you so much, Dr. Yellman.
Basic protein antibodies, Eric Johnson stated that. So those are the autoantibodies, one of them that they were detecting in these PANS and PANDAS patients.
Thank you so much, Dr. Yellman, for your time today. We want to be respectful of your cutoff, and we really appreciate this incredibly comprehensive presentation, and also appreciate taking time to answer additional questions. We will post the recording to the Remission Biome YouTube channel, and we'll announce on social media when that is ready. And thank you everyone for attending today.
Thank you.
Thank you.